All right, detectives, this is Dr. Bosnak, and welcome to drugdetectives.com question and answer channel. Here's today's clinical puzzle. We've got a 55-year-old gentleman with both hypertension and type 2 diabetes. He's already on lisinopril, an AC inhibitor, at 20 milligrams daily, but his blood pressure today is 152 over 94 millimeters of mercury. Time to figure out our next move. Let's break down the options and see what fits. A. Increase lisinopril dose. Increasing the dose of lisinopril might sound like an obvious choice, but here's the catch. He's already on 20 milligrams daily, which is close to the top of the therapeutic range. Pushing the dose higher might not give us much more bang for our buck, and it could increase the risk of side effects like high potassium. So, not the best choice here. B. Add hydrochlorothiazide. Hydrochlorothiazide is a thiazide diuretic that can definitely help lower blood pressure. It's especially useful in patients with hypertension, but what do we know about this patient's kidneys? His eGFR is 58 milliliters per minute, which means his kidney function is a bit on the low side. Thiazides aren't as effective when the eGFR is below 60, so this might not be our best bet. C. Add amlodipine. Amlodipine is a calcium channel blocker and a great choice for patients with hypertension, especially if they have diabetes. It lowers blood pressure without affecting kidney function, and it pairs well with an AC inhibitor like lisinopril. This could be the option we're looking for. D. Add spironolactone. Spironolactone is an aldosterone antagonist that's typically added for resistant hypertension or heart failure. But in this case, his potassium is 4.7 milliequivalents per liter, which is already on the high side. Adding spironolactone could push his potassium even higher, risking hyperkalemia. Not the best fit here. So, detectives, what's our best option for managing this patient's blood pressure? The answer is C. Add amlodipine. Why amlodipine? Because it's a solid choice for hypertension management, especially in patients with diabetes, and it doesn't mess with kidney function or potassium levels. It works in a different way than ACE inhibitors, so it complements the lisinopril nicely, giving us better blood pressure control without adding extra risks. Now, you might be wondering, why not increase the lisinopril or add hydrochlorothiazide? Well, with the lisinopril, he's already close to the maximum dose, so we wouldn't gain much by pushing it higher. And hydrochlorothiazide is less effective with his eGFR being just under 60, so it wouldn't give us the best results. Amlodipine, though, perfect fit. It's like the missing piece to this hypertension puzzle. And as for spironolactone, it's a powerful tool, but in this case, with his potassium already being a little high, we'd be walking on thin ice. We want to avoid any unnecessary risks of hyperkalemia. After all, we're solving the case, not creating new ones. So, what's the takeaway here for your Neplex prep? When dealing with a patient who has hypertension and diabetes, and you've already maxed out one med like an AC inhibitor, think about adding something like a calcium channel blocker. Amlodipine is your go-to in many cases. It lowers blood pressure effectively and safely without messing with the kidneys or potassium. It's all about balance, detectives. So our final answer here is C. Add amlodipine. It's like finding the right partner for lisinopril to help this patient get his blood pressure under control. Another case solved and another patient on their way to better health. Detectives, remember, when you've got multiple health factors to juggle, always look for the solution that fits them all, just like we did here. Stay sharp, detectives, and keep hunting for those clues in every patient case. Catch you on the next question. All right, detectives, let's crack this pediatric asthma case wide open. We've got a 7-year-old boy who's been relying heavily on his rescue inhaler, using it nearly every day and waking up at night with asthma symptoms. So what's the next move in our treatment plan to get his asthma under control? Let's break down our options. A, continue albuterol as needed. This is his current treatment, and while albuterol helps during acute symptoms, it's clear that it's not enough anymore. His frequent use of a rescue inhaler and nighttime awakenings are red flags indicating that his asthma isn't well controlled. We need to step up his therapy. B. Add a low-dose inhaled corticosteroid, ICS. Now, this is a solid choice. Inhaled corticosteroids are the cornerstone for long-term asthma control, especially when patients start needing their rescue inhaler more often. This could help reduce his symptoms and prevent those nighttime flare-ups. C. Add a leukotriene receptor antagonist. This could be an option too, especially if he has trouble with an inhaler or has allergy-related symptoms, but it's not the first-line choice. ICS is typically the first step in stepping up asthma management. D. Switch to oral corticosteroids. Whoa, hold up. This is usually reserved for severe exacerbations, not routine management. Oral corticosteroids come with a lot of potential side effects, so we don't go there unless absolutely necessary. So, what's the best move for our young patient here? B. Add a low-dose inhaled corticosteroid. Here's why. When a child with asthma is using their rescue inhaler more than twice a week or waking up at night due to symptoms, that's a sign that their asthma isn't under control. By adding a low-dose inhaled corticosteroid, we can reduce inflammation in the lungs and keep those asthma symptoms from flaring up. And hey, less waking up at night means more restful sleep and better performance during sports. Win-win, right? Now, why not just continue with albuterol or switch to oral steroids? Well, think of albuterol as a firefighter. It's there to put out the flames when asthma strikes. But what we need here is a fire prevention strategy, something that controls the asthma long-term. And oral corticosteroids? Those are like bringing out the big fire trucks for emergencies. We don't need that right now. This kid's asthma can be managed with a much lighter touch. Here's a tip for your Naplex prep detectives. When you see signs of uncontrolled asthma, like frequent use of a rescue inhaler, nighttime symptoms, or trouble during activities, the first step is usually to add an inhaled corticosteroid. It's all about preventing the next asthma attack before it happens. So, there you have it. We're helping this little detective breathe easy by adding an inhaled corticosteroid to his treatment plan. That's what it's all about, keeping asthma in check so he can run, play, and sleep without a hitch. Case closed, detectives. Our young patient's lungs will be thanking us, and his mom's going to love that he won't be reaching for that inhaler as often. Until next time, remember, managing asthma is all about control, not just putting out fires. Keep your inhalers ready, detectives, but let's aim for less use and more control. See you on the next case. All right, detectives, let's jump into this case. We've got a 68-year-old woman with atrial fibrillation who's currently on warfarin. Now, here's the kicker. Her recent INR is 3.8. For those keeping track, we're aiming for an INR between 2.0 and 3.0 for patients with AFib. So, what's our next step in managing her anticoagulation? Let's break it down. A. Continue current dose of warfarin. Not quite. With an INR of 3.8, she's above the target range. Continuing her current dose would likely push her INR even higher, which could increase her risk of bleeding. Not the best move. B. Decrease warfarin dose. Now, this is sounding a bit more promising. Reducing her warfarin dose could bring her INR back into the target range without causing too much fluctuation. This might be the right call. C. Stop warfarin for 1 day, then resume at the current dose. Stopping warfarin for a day can sometimes help quickly lower a high INR, but her INR is 3.8, not dangerously high. We don't need to go this far. It's not like she's at risk of immediate bleeding. Let's keep this option in our back pocket. D. Switch to rivaroxaban. Rivaroxaban is a great direct oral anticoagulant DOIC option, especially for patients with AFIB. But switching her off warfarin just because of one high INR isn't necessary. Plus, she's doing well with warfarin overall, so no need to make big changes right now. So, detectives, what's our best approach for this patient? The correct answer is B. Decrease warfarin dose. Why? Well, with an INR of 3.8, she's slightly above the therapeutic range, meaning her blood is a bit too thin, putting her at a higher risk of bleeding. By reducing her warfarin dose, we can bring that INR back into the target range, 2.0 to 3.0, and keep her safely anticoagulated without swinging too far in the other direction. Now, you might be asking, why not stop warfarin for a day or switch to rivaroxaban? Good questions, but her INR isn't so high that we need to stop her therapy. It's not in the dangerous zone where immediate action is needed. And while the OX, like rivaroxaban, are excellent options for AFib, this patient has been managing well on warfarin. It's just a matter of fine-tuning the dose, not overhauling her treatment. And we all know how warfarin can be tricky. Just a small adjustment can make a big difference, but hey, that's why we as drug detectives pay close attention to the clues in a patient's lab results. It's all about precision here, folks. Here's the takeaway for your Naplex. When managing patients on warfarin, if their INR creeps above the target range but they are not showing any signs of bleeding, the best approach is often to decrease the dose. Don't panic, just adjust. And always monitor carefully to keep them in that sweet spot. So, detectives, the final answer here is B, decrease warfarin dose. We are not overreacting, just fine-tuning. Another case solved and another patient kept safe from the dangers of too much or too little anticoagulation. That's what we do. Solve the mysteries of medicine, one case at a time. Until next time, keep those Indian rupee numbers in check and your detective hats on. Stay sharp out there, detectives, and remember, every number counts, but it's the fine adjustments that win the day. Today is enough. See you next video. Bye-bye.